Alright, so howdy. So today we'll be talking about antihypertensives, which are essentially a class of medication intended to lower blood pressure. This video will focus on the subclass of antihypertensives that are calcium channel blockers. Alright, so first off, hypertension. Hyper meaning excessive in medical terms, and tension refers to the pressure within a vessel, or the force against the vessel's wall, in this case arterial blood vessels. Hence, hypertension is where the force exerted by circulating blood pressing against artery walls is too high. For many common chronic diseases such as heart failure and stroke, hypertension is a notable risk factor. As such, antihypertensives are anti-high blood pressure agents. Moreover, it should be recognized that although this video has a focus on calcium channel blockers, it does not imply that this or other classes of antihypertensive drugs are equally effective and safe in all patients. Antihypertensive drugs are usually used in conjunction with other drugs. Notably, comorbidities influences what drug classes are utilized in the treatment of hypertension in most cases. First off, we should outline basic function of the heart. So to put it simply, the heart pumps oxygenated blood through arteries to distribute it around various bodily tissues. The oxygenated blood is returned to the right atrium of the heart via veins. So the atrial chamber of the heart is typically at low pressure when blood flows in and the ventricles are at high pressure. Here, heart contraction results in high arterial pressure that forces blood flow throughout the circulatory system. Arterial meaning arteries, the blood vessels that transport oxygenated blood. So, blood pressure in the arteries is influenced by the ejection of blood from the left ventricle into the systemic vasculature, which is the blood vessels system that provides functional blood throughout the body. However, blood pressure is also maintained by multiple things such as elasticity of artery walls, so how stiff they are, blood volume, and systemic vascular resistance, the resistance to blood flow in arteries. It should also be recognized that other organs can influence blood pressure, for instance, the kidneys, liver, lungs, and adrenal glands. In doing so, hypertension can be identified by measuring the systolic blood pressure, the arterial pressure when blood is being pumped out of the heart, on top of the diastolic blood pressure, which is the arterial pressure when blood refills the arteries, so when the heart is at rest between contraction. Here, normal blood pressure is recognized as having less than 120 systolic over 80 diastolic. Hypertension is usually diagnosed in patients with a systolic blood pressure of 140 over 90 diastolic. Any reading in between normal and hypertension is considered prehypertensive. In understanding this, there are a range of antihypertensive drugs that can be used to treat hypertensive conditions. For instance, beta blockers, angiotensin converting enzyme inhibitor, known as ACEs, and diuretics being common antihypertensive treatments. These essentially function by interrupting different aspects of regulatory systems for blood pressure. However, this video, our main focus is on calcium channel blockers. Calcium channel blockers, or calcium antagonists, is a prescription medication that is commonly taken orally. As the name indicates, they block calcium channels, reducing the heart's workload with oxygen and blood supply increasing as blood vessels are relaxed. Essentially, calcium channel blockers act to inhibit extracellular calcium flow through calcium channels that are ion specific and situated on cellular walls. These calcium channels regulate calcium influx in both cardiac muscle cells and smooth muscle cells that tighten blood vessels in this case, which in turn contributes to stimulating the respective muscle contraction. There are two main subdivisions of calcium channel blockers utilized in hypertension treatment. The first subclass being dihydropyridines and the second being the intuitively named non-dihydropyridines. Dihydropyridines decrease blood pressure by dilating systemic arteries and capillaries. Non-dihydropyridines reduce heart rate, contractility, and slightly increasing dilation of arteries. These subdivisions vary in their relative selectivity towards vascular or cardiac L-type calcium channels, in addition to their basic chemical structure. Okay, so both types of calcium channel blockers act on vascular smooth muscle cells. This is significant in treating hypertension as vascular smooth muscle cells is a majority of the vascular wall, influencing blood flow and as such pressure. This is because in the arteries, as resistance increases, blood flow decreases and blood pressure rises. Here, three aspects have notable influence in determining blood flow resistance. 1. Blood viscosity, the thickness of the blood. 2. Arterial length, the distance the blood has to travel. 3. Vessel diameter, or the radius of the blood vessels. This can be explained using Poiseuille's law, as lumen diameter, or radius of the vessel, is inversely proportional to blood vessel resistance. And sorry if I pronounced that wrong. Therefore, blood vessel diameter changes can influence vascular resistance significantly. Calcium channel blockers typically intend to increase vasodilation of the lumen, increasing their diameter and reducing high blood pressure. Okay, so dihydropyridines act on vascular smooth muscle, selectively inhibiting L-type calcium channels. This is intended to induce vasodilation, the increasing of blood vessel diameter, which would lower blood pressure. These L-type calcium ion channels are usually high voltage activated or voltage gated. The physiological basis of this is that in vascular smooth muscle excitation contraction, intracellular calcium concentrations increases, so calcium within the cell, as a response to electrochemical stimuli. Here, calcium concentrations are normally regulated by calcium permeable exchanges, transporters, and channels in the plasma membrane. The vascular smooth muscle vasoconstriction, so narrowing blood vessel diameter, is triggered by increased intracellular calcium concentrations that promote actin-myosin cross-bridge formation, hence constriction. Conversely, relaxation of smooth muscle happens with decreases in intracellular calcium concentrations, which can occur with L-type calcium channel inactivation. As such, calcium channel blockers inhibit the calcium influx into cells. This helps hypertension, as calcium entering smooth muscle cells typically leads to contraction, which results in vascular resistance increasing and thusly respective blood pressure increases. Inducing relaxation of vascular smooth muscles, calcium channel blockers reduce systemic resistance in blood vessels as their diameter increases, lowering arterial blood pressure. Examples of drugs from this group include nifedipine and nicardipine. It is generally safe, but common side effects that have been recognized from these drugs include flushing, headache, dizziness, palpitations, so rapid or strong heartbeats, and pedal edema, which is the swelling of the feet. Another potential side effect identified is gingival hyperplasia, which is gum swelling. Non-dihydropyridines are similar to dihydropyridines regarding the fact that they are L-type calcium channel inhibitors. However, they are non-selective in this inhibition. So, this subdivision of drugs inhibit vascular smooth muscle calcium channels just discussed, in addition to cardiac cell calcium channels, thus results in the same effects discussed previously, as well as reduced cardiac muscle cell contractility, slower heart rate, and slower conduction, reducing high blood pressure. Okay, so cardiac muscle cells are not that different from skeletal muscle in the sense that both are striated in appearance and contain sarcomeres with thick myosin and thin actin filaments, the functional unit of muscle fibers. Although cardiac muscle cell contraction is not initiated in the same manner as skeletal muscle through neuron signals, but by the heart's pacemakers such as the SA node, which is responsible for electrical excitation. Normally, this process is understood through calcium-induced calcium release and excitation-contraction coupling processes in myocardial cells, the contractile cell of the heart. To put it briefly, an action potential from a pacemaker spreads to a cell's membrane through T-tubules. Here, calcium conductance rises as calcium enters the cell through extracellular fluid outside of the cell. This inward calcium current enters through L-type calcium channels that are voltage gated, so channels that are activated by electrical membrane potential changes. This is the target of non-dihydropyridines. From here, the released calcium has a cascade-like effect as it initiates the sarcoplasmic reticulum into releasing more calcium through release channels called ryanodine receptors, hence calcium-induced calcium release. The quantities of calcium freed from the sarcoplasmic reticulum is dependent on the calcium concentration stored in it initially, as well as the size of calcium signals that enter the intracellular fluid through L-type calcium channels. Calcium released from the sarcoplasmic reticulum form calcium signals. This signal contributes to removing an inhibition of actin and myosin binding. So myosin and actin bind, which results in thin and thick filaments sliding past each other, so a myocardial cell contraction. The extent of tension that develops here is proportional to the intracellular calcium concentrations. As such, non-dihydropyridine non-selectively inhibiting L-type calcium channels has notable implications on myocardial cell contraction. Blocking L-type calcium channels results in reduced calcium conductance entering cells from extracellular fluid as L-type channel passage is inhibited. This would as such result in less calcium interacting with ryanodine receptors of the sarcoplasmic reticulum, subsequently resulting in reduced inducement of calcium signals being released from the sarcoplasmic reticulum. This is important because the magnitude of muscle contraction tension is proportional to the intracellular calcium concentration. So because there is less intracellular calcium as a result of the process being interrupted, there would be decreased contraction of myocardial cells. In doing so, the blocking of calcium entering into cells by calcium channel blockers can lead to vasodilation, the relaxation of contractile units of the cell, reduced heart rate, reduced force generation of heart contraction, and reduced velocity of conduction within the heart, which can lead to a lower blood pressure. Examples of non-dihydropyridines are diltiazem and verapamil. A literature review of drugs such as these in 2019 recognized constipation, headache, impotence, dry mouth, edema, so swelling, rash, nausea, and fatigue as the most commonly reported side effects for these drugs. Additionally, non-dihydropyridines are typically not the first drug of choice in patients with high risk of heart failure due to their left ventricular function being reduced, as they could make the condition worse. And yeah, so that concludes this video on antihypertensive drugs, the subclass calcium channel blockers. And yeah, so thanks for watching.